Excision of pilonidal cyst or sinus, simple. Extensive. Complicated. Physician uses a scalpel to completely excise the involved tissue. The wound is sutured in a single layer. The extensive sinus is superficial to the underlying fascia but has subcutaneous extensions. The physician uses a scalpel to completely excise the lesion. The wound may be sutured in several layers. The sinus is more complicated and has many subcutaneous extensions. The physician uses a scalpel to completely excise the involved tissue. Local soft tissue flaps, i.e., Z-plasty, may be required for closure of a large defect, or the wound may be left open to heal by granulation. Excision of sublingual salivary cyst, ranula. The physician removes a sublingual salivary cyst. An incision is made intraorally in the floor of the mouth overlying the cyst. The physician removes the cyst. Excision of Mullerian duct cyst. Through an incision in the lower abdomen or an incision in the perineum, the seminal vesicle is approached. The surgeon dissects the cyst free of its attachments and clips it at the attachment to the seminal vesicle and removes it. The operative wounds are closed in layers by suturing. Excision of vaginal cyst or tumor. Through a speculum inserted in the vagina, the physician uses a forceps or hemostat clamp to grasp and elongate the vaginal tissue containing the cyst or tumor, causing the mucosa to tent. With a scalpel or scissors, the physician excises an ellipse of tissue containing the lesion. The defect is closed with absorbable sutures. Excision of Bartheline's gland or cyst. The physician removes a cystic Bartheline's gland, which lies at the tail end of the bulb of the vestibular opening just inside of the vagina. The physician makes an incision through the vaginal mucosa. The cyst is isolated through the vaginal incision by dissecting the deeper fatty tissues and excised. The remaining cavity and skin are closed in layers using absorbable material. Excision of synovial cyst of popliteal space, e.g., Baker's cyst. A Baker's cyst is located in the popliteal space, back of the knee. The physician makes a popliteal incision, carrying dissection to expose the semimembranosus tendon. The cyst is typically located around this tendon. The cyst is excised from the tendon. The incision is repaired in layers with sutures. Excision of Choledocal cyst. The physician excises a cyst in the common bile duct. The physician exposes the liver and gallbladder via an upper midline or subcostal incision made through skin, fascia, and muscle. The cyst is exposed and excised and the defect of the biliary system is repaired. The abdominal incision is closed with layered sutures. Excision of urachal cyst or sinus, with or without umbilical hernia repair. The physician makes an incision in the lower abdomen through the umbilicus, and cuts the corresponding muscles, fat, and fascia. After isolating the urachus with a clamp, the physician excises the urachal cyst or sinus and a small cuff of the bladder. The physician sutures the bladder and removes the urachal tissue, leaving the navel intact. After inserting a drain tube and urethral catheter, the physician performs a layered closure. Excision or unroofing of cyst, S, of kidney. Excision of paranephric cyst. Physician makes an incision in the skin of the flank, cuts the muscles, fat, and fascia overlying the kidney, and sometimes removes a portion of the 12th rib. After clearing away the fatty tissue surrounding the kidney, the physician excises the cyst from the renal surface. The physician destroys tiny vessels bordering the cyst with high-frequency electric current, fulguration, to minimize the need for sutures. If the cyst requires a deep excision, the physician usually sutures the renal tissue. The physician inserts a drain tube, bringing it out through a separate stab incision in the skin, and performs a layered closure. Excision branchial cleft cyst or vestige, confined to skin and subcutaneous tissues. The physician removes a branchial cleft cyst or vestige that is confined to the skin and subcutaneous tissues of the neck. A branchial cleft is an abnormal embryological remnant that resembles gills. The physician makes a horizontal neck incision just below the jawline to access and remove the cyst or vestige. The incision is repaired in sutured layers. Excision branchial cleft cyst, vestige, or fistula, extending beneath subcutaneous tissues and/or into pharynx. The physician makes 1 or 2 horizontal neck incisions just below the jawline. The cyst or vestige is dissected from the surrounding muscle and fascia. If a fistula is present, a surrounding elliptical skin excision is performed. Any ducts of the cyst are dissected and traced to a pharyngeal communication. The cyst, vestige, and ducts are removed. A tissue drain is placed and the wound is sutured in layers. Excision of thyroglossal duct cyst or sinus. Recurrent. The physician excises a thyroglossal duct cyst or sinus. The physician circumferentially incises the skin around the cyst or sinus and extends the incision along the tract to its origin. The midpart of the hyoid bone is excised. The wound is packed and allowed to heal by secondary intention. Excision dermoid cyst, nose, simple, skin, subcutaneous. Complex, under bone or cartilage. The physician removes a dermoid, developmental, cyst of the nose that may be associated with the soft tissue only or may extend into bone and/or cartilage. If associated with the nasal bone, the usual location is at the bone-cartilage junction. Dependent on the size and location, the cyst may be removed using skin or intranasal incisions. A fistula opening may be present and its tract would be excised. Commonly, an incision is made overlying the cyst in the nasal skin. The cyst is removed from its cavity using curettes. The defect size dictates post-removal cavity packing and/or separately reportable reconstruction. Incisions may be closed in single and layers. Excision of ganglion, wrist, dorsal or volar, primary. Recurrent. An incision is made overlying the ganglion. The tissues are dissected around the ganglion, freeing it from surrounding tissue. The physician may dissect deep within the wrist joint in order to excise all of the ganglion. The ganglion is removed. The joint or muscle tissue may be repaired. The physician irrigates the wound with antibiotic solution and closes the wound in layers.